السلام عليكم. اليوم هي المحاضرة الرابعة والأخيرة من ال Endocrine System, which will discuss topics related to the adrenal gland pathology. We will divide them into those of the adrenal cortex and those of adrenal medulla, whether it is a hyperfunction, hypofunction, or tumor. Now we will start with the structure and histology of adrenal gland. They are paired glands. We have two adrenal glands. They located in suprarenal location above the right and above the left kidney. The gland is triangular in shape. It is surrounded by a capsule, and there are two areas, the cortex and the medulla. The cortex is the outer yellowish part of the gland due to the content of lipid, because the hormones are lipid in nature, and there is the medulla, which appear brown in color grossly. The cortex has three layers: outer thin zona glomerulus, then zona reticularis above the medulla, and we have this large zona fasciculata zone. This secretes the mineralocorticoid aldosterone, this secrete the glucocorticoids and the cortisol, and these secrete the sex hormones or the androgens.
Again, we summarize the constituents of the adrenal gland and their secretory products. The adrenal glands are paired organs of both cortex and medulla. The cortex synthesizes three different types of steroid. The glucocorticoids مثل ما قلنا principally the cortisol والاسم جاي من glucose, cortex and steroid. This is a steroid hormone from the cortex that is concerned with the glucose metabolism in the body. Okay, the mineralocorticoids, I mean the cortical steroid that is concerned with mineral regulation. The most importantly is the aldosterone, which work on the kidney to increase sodium and water resorption and excretion of potassium. The sex steroid, the estrogens and the androgens. The adrenal medulla is different from the adrenal cortex. It is derived from the neural crest cells. It has neuroendocrine cells. They have neuronal and endocrine function. Their constituent cells are called chromaffin cells، وهذا الاسم اجى من كروميوم وافينيتي، يعني الجاذبية او الانجذاب نحو الكروميوم، لان بالبداية صبغوها بالكروميوم سيلز، املاح الكروم، فكان الكروميوم يؤدي الى اكسدة النورابينفرين الكاتيكولامينز اللي داخلها، وتظهر لنا باللون الجوزي براون كلر، اللي سميناها كرومافين سيلز. هذه تصنعني الكاتيكول امينز الابنفرين خصوصا 80%، اللي اسمه الاخر هو الادرينالين، والنور ادرينالين اللي هو نور ابنفرين 20% تقريبا. وظيفة الادرينال ميدلا والكاتيكولامينز وظيفة واسعة، منها تنظيم السمباثيتك اكتيفيتي، ريسبيراتوري فانكشن، وكذلك البلد بريشر. وتعرفون انه هي كان sense the stress, increase the secretion of catecholamines in stressful situation, hence the effect of adrenaline like tachycardia and increase blood pressure, etc. Okay, so this is a simple overview about the constituent of the adrenal gland and their composing cells. Now this is the general classification of diseases that affect the adrenal glands. As a gland in general, it is either a hyperfunction of that gland, hyperproduction of hormone, or a hypofunction and hypoproduction or deficiency of a hormone. A third category of diseases is always the neoplasms, and neoplasms sometimes are associated with the hyperfunction and or the deficiency, just like we discussed in the pituitary gland. Diseases affecting the adrenal medulla، بالإضافة إلى أنه إحنا صنف له التصنيف الأولي إلى هايبر وهايبو ونيوبلازم، هي أيضا تقسم حسب الاناتوميكال region إلى those affecting the cortex and those affecting or stemming from the medulla. We start with the cortical diseases: adrenocortical hyperfunction, the hyperadrenalism, or the adrenal insufficiency hypofunction, which is either a primary or secondary. Hyperfunction could involve any one of the three major hormones produced. An increase in cortisol secretion will lead to Cushing syndrome. An increase in aldosterone lead to hyperaldosteronism. An increase in sex hormone lead to adrenogenital syndromes. Insufficiency could be, as we say, the primary. It is called Addison disease, or secondary to other destructive process involving the adrenal medulla. Cortex. For the adrenal medulla, the most important disease that affect the adrenal medulla are the tumors. Two major tumors, the neuroblastoma stemming or originating from a neuroblast. These mainly occur in children, and the pheochromocytoma, which originate from the chromaffin cell that secrete the adrenaline and the noradrenaline.
We'll start with the first of the adrenal cortical syndromes. It is hyperadrenalism, it is hypercortisolism, and it is also called the Cushing syndrome due to excess secretion of glucocorticoids and the cortisol. This is caused by any condition that produce an elevation in glucocorticoid levels. بغض النظر جايني هذا الجلوكوكورتيكويد from the adrenal itself or exogenous source. المهم عندي blood level elevated وأسميها ب Cushing syndrome because they all present with the same clinical manifestation, general clinical manifestation. Cushing can be broadly divided into an exogenous and endogenous. معظم الحالات of Cushing هي نتيجة administration of exogenous glucocorticoid. أسميها iatrogenic Cushing لأنه السبب هو خطأ بعملية إعطاء الجلوكوكورتيكويد إما within medical treatment or self intake of glucocorticoids like what is happening in some of traditional as part of some traditional beliefs in our communities حتى يزيد البودي ويت of females أو غيرها. الانdogenous in turn divided into those that are ACTH dependent يعني السبب لزيادة إفراز الكورتيزول from the adrenal is overstimulation by excess ACTH secreted from the pituitary gland. Whether we are, for example, dealing with a pituitary adenoma that is secreting ACTH or ectopic production. And those that are ACTH independent, which mean we have now a primary source or primary problem in the adrenal gland, like adenoma, carcinoma, or primary hyperplasia in the adrenal. So it is either ACTH dependent, يعني secondary, or ACTH independent.
This table will show you and summarize to you the causes of Cushing syndrome. General classification or division of this syndrome causes into ACTH dependent مثل ما قلنا أو ACTH independent. ACTH dependent Cushing disease، وانتبهوا مرة ثانية على المصطلحات، هذا نتيجة pituitary adenoma أو rarely يكون عندنا pituitary hyperplasia. ركزوا وياه على pituitary adenoma، و70% من الكوزز of Cushing syndrome هي ACTH dependent Cushing disease due to secretion of ACTH from the pituitary adenoma. Also, there is ectopic corticotropin syndrome, ectopic secretion of the adrenocorticotropic hormone, like, for example, from small cell carcinoma of the lung, or a tumor called the bronchial carcinoid, which is a neuroendocrine tumor in the bronchi. ال ACTH independent يعني السبب يجينا من الادرينال gland. It's a primary cause as the adrenal gland. Either most commonly an adrenal adenoma, a tumor, a benign tumor in the adrenal cortex that produce corticosteroid, glucocorticoid or cortisol. Less commonly could be adrenal carcinoma secreting this cortisol. It could be also a hyperplastic process. هنا primary hyperplasia not secondary to increase ACTH. أكيد من أكو increase بال ACTH وتحفيز مستمر للأدرينال gland يصير عندنا hyperplasia بالأدرينال cortex، وهذا تكون secondary. هنا أكو primary adrenal hyperplasia either taking the form of macronodular لما يكون عندي nodules بالأدرينال cortex كبيرة بالحجم سنتيم وفوق، أو يكون عندي primary pigmented cortical hyperplasia. هنا small nodules that are pigmented. وكو عندنا هذه السندروم، هذه اصلا عندهم طفرات في هذا الجينات اللي مر عليكم ايضا بالبيتيوتري، وهذا يحفز ال proliferation of several endocrine organs، وياها طبعا bone lesion وskin disease. This is another schematic representation for the major forms of hypercortisolism or Cushing syndrome. ثلاث أنواع endogenous، والنوع الأكثر شيوعا هو الإكزوجينس الإياتروجينيك Cushing syndrome. The iatrogenic intake of excessive steroid intake, this will lead to Cushing syndrome، ونفس الوقت تؤدينا إلى ضمور بالغدة الكظرية بسبب أنه أكو عندك سورس خارجي، ال ACTH راح يتثبط inhibition B، والأدرينال will atrophy. الأسباب الأخرى most common endogenous cause هو pituitary Cushing syndrome, increased secretion of ACTH from the pituitary gland tumor leading to adrenal hyperplasia and excessive secretion of cortisol. It could be an ectopic production of ACTH from a lung tumor leading to such hyperplasia and cortisol secretion, or it could be a primary adrenal tumor secreting cortisol, or a primary nodular hyperplasia secreting cortisol. لاحظوا هنا عندنا اتروفي، هذا سنجي على المورفولوجي، اتروفي بالجلاند بالاكزوجينس، او hyperplasia both are secondary، a primary hyperplasia or a tumor. These are the morphological manifestation seen in the adrenal in the setting of Cushing syndrome. Depending on the cause, as we said, the morphology will be decided in the adrenals in the setting of Cushing syndrome. If the patient in whom the syndrome resulted from exogenous glucocorticoid intake, there will be suppression for endogenous ACTH, and this will result in bilateral cortical atrophy. مثل ما شفنا من يكون عندي مصدر خارجي راح يصير عندي feedback inhibition للsecretion of the ACTH، وبالتالي يكون عندنا bilateral cortical atrophy because of the lack of stimulation للadrenals. In contrast, when there is endogenous hypercortisolism, the adrenals either تكون hyperplastic، سواء كان السورس من البيتيوتري، سواء كان السورس ectopic، سواء كانت primary hyperplasia، or it could contain a cortical neoplasm like adenoma, carcinoma, which secrete this excess cortisol. So these are the various morphological patterns occurring in the adrenals.
This photo show you comparison between a normal adrenal gland and a hyperplastic adrenal gland. You can see the cortex with the yellow color and the medulla with the brown color in the normal gland, and you can see the thickened cortex in the hyperplastic gland, involving the whole cortex of the organ, compressing the medulla, and you can see that there is also some form of subtle nodularity. Here is one, here is one, here is one in the cortex of the adrenal gland. This is an adrenocortical adenoma. You can see the cortex here, the yellowish cortex, the light brown medulla with abundant prominent vascularity. There is a well circumscribed lobulated mass, yellowish in color, that is arising from the cortex, but still respecting the intact overlying capsule. The histology of adrenal adenoma show these zona fasciculata cells. These cells have vacuolated cytoplasm, many vacuolation in the cytoplasm due to the presence of abundant glucocorticoids in their cytoplasm. There is some sort of atipia and pleomorphism between the constituent cells, different sizes. But however, the atipia is mild. This is not accompanied by significant increase in mitotic activity or areas of necrosis, which are more characteristic of carcinoma. Now, regarding the clinical features of Cushing syndrome, طبعا هو الهرمونز اللي تفرزها الجلوكوكورتيكويدز. هنا راح يصير عندنا exaggeration بالphysiological effect of that hormone. The earliest manifestation هو إنه البيشنت will present complaining of hypertension and a weight gain. The pattern of weight gain is that there is what is called as centripetal obesity or central obesity. There is redistribution of the fatty tissue due to this glucocorticoid oversecretion. The patient is complaining of moon face. There is also central truncal obesity. There is also an increase in the fat in the shoulders and neck, called bovalo hump. The CNS manifestation, psychiatric manifestation, including irritability and personality changes. Because the glucocorticoid stimulates synthesis of glucose and prevent the uptake of glucose by the cells, it will produce features of hyperglycemia. In addition, uh, the metabolic effect of the glucocorticoid will also involve breakdown of excessive proteins like the collagen from the skin. That's why the skin will appear as fragile with easily bruising and striae formation, like these purple striae occurring most commonly in the abdominal area. The action of glucocorticoid and calcium will lead to excessive and accelerated osteoporosis with increased tendency for fracture. The sexual effects include hirsutism and amenorrhea and in male gynecomastia.
This is a table also showing you the clinical manifestation. Obesity or weight gain occur in 95% of the cases. There is an increased plethora, يعني red color in the face because of vasodilation, rounded face, decreasing libido in most of the patients, thin skin also as a common feature, affect the growth in children because of the metabolic disturbances, menstrual irregularities, hypertension, hirsutism, and there are also the depression and the emotional liability, the easy bruising in the skin, glucose intolerance, weakness as we explained, osteopenia and fracture تأثيراتها على العظام. وبسبب هذا السحب المفرط للكالسيوم من العظام وممكن أن يؤدي إلى نفروليثياسيس يعني كالسيوم ستونز in the kidneys. This is a real photo for a patient with Cushing syndrome. You can notice the moon face, the rounded face, the central obesity, and the characteristic striae that occur here. Maybe some degree of gynecomastia, but they are not quite apparent. يعني مو كل الفيتشرز ممكن تلقاها في مريض واحد.
ناخذ ملاحظات بسيطة عن الهايبر الدوستيرونيزم أو الإكسس mineralocorticoid, which is the second group of adrenal cortical hyperfunction بعد الكوشنج syndrome. نضطر أنه نختصر الموضوع بسبب ضيق الوقت وغزارة المواضيع الموجودة، على أمل أن تطلعون على تفاصيل أكثر بالمستقبل. الهايبرالدوستيرونيزم any condition characterized by chronic elevation of aldosterone levels. انقسم إلى primary و secondary حسب المصدر المشكلة. primary from the adrenal، إما أن يكون عندنا idiopathic hyperplasia of the adrenal أو أيضا تيومر مثل ما صار عندنا بالكوشنج سيندروم. وهنا التيومر أدينوما أو كارسينوما، بدل ما تفرز جلوكوكورتيكويد تفرز لنا الدوستيرون. معظم هذه التيومرز مثل ما بالكوشنج ايضا هي الادينوما. وعندنا الحاله لما يكون عندنا سوليتري ادينوما تفرز لنا اكسس الدوستيرون، هذه الحاله اسميها بالكون سيندروم، هايبر الدوستيرونيزم due to solitary adrenal cortical adenoma. secondary causes مثل ما تعرفون وسامعين بالرنين انجيوتنسين الدوستيرون سيستم، هذا له علاقه بالووتر والصوديوم بالانس بالبودي. يحصل لما يكون عندي hypotension hypovolemia decrease renal perfusion. اكو عندنا خلايا بصف الجلوميريلاس مالت الكدني جكستا جلوميريلار ابارتس، هذا يفرز لي الرنين والرنين راح يحفز انتاج الالدوستيرون حتى يسحب الووتر والصوديوم. هنا أنا خلاصة primary hyperaldosteronism most common cause is the idiopathic hyperaldosteronism due to hyperplastic process. Second most frequent cause is an adenoma from the cortex that secrete aldosteronism. The increased aldosterone work on the kidney, on the renal tubules to absorb sodium into the bloodstream with accompanied water reabsorption, and there is also potassium excretion in return. The potassium will goes with the urine, so there will be hypertension. The resultant effect is hypertension with hypokalemia. Acute insufficiency, adrenal crisis occur in these three situations. Patient already complaining of chronic insufficiency. هذول اللي قدام عندهم chronic insufficiency. For example, they are complaining from a chronic infection that is affecting the adrenal. 50, 60, 70% of the gland might be destroyed. A sudden stress on these already compromised gland will lead to crisis. شو وقت يحصل هذا sudden stress? No, when there is a new infection, a surgical procedure, fever, كل هذه الأشياء تسبب لي ستريس على الادرينال جلاند. السيتويشن الآخر لما البيشنت هو on chronic treatment with corticosteroids for any reason، مثلا يعاني من autoimmune disease، عنده chronic inflammatory disorder، عنده neoplasms، نعطيه corticosteroid، وهنا ممكن الكورتيكوستيرويد suddenly نوقفها او ينسحب بشكل خاطئ او يتقلل الدوز مالتها بشكل خاطئ، لان عادة احنا من ننطي ستيرويد لفترة طويلة وراها لازم ما نقطع بشكل مفاجئ اذا اكثر من اسبوع او 10 ايام، لازم نبدي نقطعه بشكل تدريجي، وهذه العملية نسميها بالتيبرينج حتى نسمح بالادرينال جلاند ان ترجع تشتغل، لان هي already suppressed by this exogenous treatment. sudden withdrawal for the treatment او a new stressful event، هم من هذا المريض اللي دا ياخذ ستيرويد صار عنده انفكشن او سيرجري وما زيدنا له جرعة الستيرويد اللي دا ياخذها، فهم راح يبين عنده decompensation ويوصل الى adrenal crisis. بعد الحالة الثالثة من يصير عندي severe adrenal hemorrhage بسبب معين، مثلا patient دا ياخذ anticoagulant therapy بجرعة عالية وصار عنده هذا الهيموريج، اكو عندنا disseminated intravascular coagulation. وممكن هذا الهيموريج ايضا يصير in the setting of sepsis، there is septicemia، والسبتسيميا ممكن تؤدي لي الى vascular disorders، وممكن يصير عندي hemorrhage inside the gland. هذا السيتويشن هذا السندروم اسميها بالووتر هاوس فريدريكسن syndrome. هذه بها catastrophic consequences. Already the patient is complaining of sepsis, already he is in devastating situation. Now he developed severe hemorrhage in the adrenal, there is acute adrenal insufficiency. The patient will rapidly succumb to coma and death. The most common bacteria, the culprit bacteria responsible for this syndrome is the Neisseria meningitis, which is seen especially in children. Children are more prone to develop adrenal insufficiency and Waterhouse-Friderichsen syndrome. Chronic adrenal insufficiency called Addison disease. This is uncommon disorder resulting from progressive destruction of the adrenal cortex. أي شيء يسبب لنا progressive destruction للadrenal cortex ممكن يؤدي إلى chronic insufficiency or Addison disease. تبدأ الكلينيكال manifestation تظهر لما at least 90% of the cortex has been destructed، يعني لأن هو يتأخر بالبرزنتيشن. واحدة من هالأشياء الأربعة، الأسباب الأربعة تؤدي إلى أديسون ديزيز. أما عندي autoimmune adrenalitis مثل ما الاسم يعني، أكو عندنا التهاب inflammation بالadrenal glands because of autoimmunity. This is a most common cause in the developed countries، بينما بالبلدان الأخرى مثل بلداننا الانفكشيوس كوزز هي الأكثر. الثانية هي التوبركلوسيس involvement of the adrenal glands by TB granuloma could lead to destruction of the both cortex and medulla. tuberculosis كان بالماضي كثير بالبلدان الغربية، قل بالسنوات الأخيرة، ثم رجع يظهر من جديد بسبب الاميون ديفيشنسي بروبلمز اللي تصير عندهم بسبب الايدز، بسبب الاكوارد اميون ديفيشنسي سيندروم. فالايدز زيد لنا الريت اوف tuberculosis، والايدز ايضا يؤدي الى more opportunistic infection. For example, cytomegalovirus infection with affection of the adrenal gland, fungal infection, different fungi could proliferate in the setting of immune deficiency. Fourth, is metastatic cancer coming from elsewhere to involve the adrenal, especially bilateral affection. Uh, Cancers from the breast and the lung are the most common tumors that metastasize and involve the adrenals. Now, what is the morphology in hypoadrenalism, whether acute or chronic? It depends on the cause, and we specifically talk on Addison disease. Mostly in acute situation, we will find hemorrhage. In Addison disease, the adrenal gland are shrunken and irregular because this is progressive destruction of the gland. They appear shrunken and they appear as irregular ومن الصعب تمييزها بالبرينفريك fat في مكان الادرينال اللي هي اصلا surrounded by the perinephric fat. In secondary hypoadrenalism, when the cause is in the pituitary or hypothalamus and there is deficiency in ACTH, the ACTH lack will lead to atrophy in the gland. ماكو stimulatory effect إلها. طيب هنا أيضا atrophy، هنا أيضا زغرت، لكن الاتروفي هنا يختلف لأنه الجلاند راح تكون uniformly small flattened صغرانة ككل، وليس مثل هنا تكون irregular ومجعدة. وتبقى أيضا الجلاند شوية بيها لون أصفر بسبب بقايا ليبيد بيها. In metastatic cancers, for example, the gland are بالعكس تكون paradoxically enlarged هنا because of the involvement by the tumor. Microscopically, in Addison disease, the cortex of the gland will contain only scattered residual cortical cells. Remember, it's a destructive process, for example, by the autoimmune inflammation or by infection. So we'll find few residual cells, viable cells, within the network of the connective tissue مالت الادرينال. وطبعا ممكن يكون عندي lymphoid infiltration كما في حالة الautoimmune adrenalitis or in some of the infection. Okay. What are the clinical features of Addison disease? Patient في البداية يجي لي with insidious onset of weakness and easy fatigability. المريض تعبان يعاني من تعب ما مبرر، كان هاي الأعمال يقوم بها بالسابق بدون متأثر عليه. بالأشهر الأخيرة بدأ يحس أنه هو of poor health, he is complaining of weakness, lack of energy, easily fatigued for ordinary stuff. Then the patient will develop loss of appetite, anorexia, accompanied by nausea and vomiting if the condition is more progressing and severe. وصعب عليه يبدي ياكل وراح يبدي يعاني من الويت لوس. ايضا diarrhea حتكون احدى الفيتشرز. Because of the lack of the aldosterone خصوصا بالبرايمري forms, while in secondary forms aldosterone is relatively maintained. Because of lack of aldosterone, potassium will be elevated. It will no further secreted in the urine. Sodium is lost in the urine. There is hyponatremia, hyperkalemia, and there is accompanying water deficiency and hypotension. There is hyperpigmentation, especially in the primary form. Why in the primary form? ACTH secreted in excess from the pituitary gland to compensate for this hypoadrenalism. ال ACTH ينصنع من جزيئة هي البرو أوبيو ميلانوكورتين موجودة بالخلايا اللي يسموها الكورتيكوتروف بالبيتيوتري المسؤولة عن صناعة ال ACTH. فزيادة ال ACTH production will be also accompanied by increase in melanocyte stimulating hormone. Why? Because melanocyte stimulating hormone, adrenocorticotropic hormone, both descend and synthesize from the pro-opiomelanocortin. Okay, so there will be an increase in POMC, an increase in ACTH, an increase in melanocyte stimulating hormone. These stimulate the melanocyte in the skin and the mucous membranes of the patients, activating them to produce more melanin. When يظهر لنا الهايبربيجمنtation in many sites of the body لكن الأكزيلي, النيبلز, الأريولاز, الgroins, البرينيوم are some of the affected, mostly affected site. Lack of cortisol and glucocorticoids might lead to patient to develop hypoglycemia and also glycosuria. Adrenal crisis. Now, why adrenal crisis? What are the manifestations of acute deficiency? The patient in a crisis will suffer from intractable vomiting. احنا عرفنا الفوميتنج ممكن يصير، لكن هنا يكون كلش severe intractable vomiting accompanied by hypotension. وبعدين the patient بسبب electrolyte disturbance والvomiting والhypotension will progress, and also by other mechanisms will progress to coma, shock, hypotension, shock, and there rapidly it will be a fatal condition unless corticosteroid given to the patient. These photos show you the hyperpigmentation in primary adrenal insufficiency. For example, now affecting the back of the elbows, the palmar creases, the gums of the patient, and in this photo, even the hand is affected, the dorsum of the hand, and you can see a combination of hyperpigmentation and vitiligo. hyperpigmentation عرفت السبب مالتها وشنو علاقة الميلانوسايت ستيميليتنج هرمون بالاي سي تي اتش. الفيتيلايجو ليش؟ الفيتيلايجو هنا هو consequence of autoantibodies occurring in the setting of autoimmune adrenalitis that affect the skin melanocyte and lead to hypopigmentation. So this is a clue for the cause of adrenal insufficiency in this situation is the autoimmune adrenalitis. Now we discuss the pathology of the adrenal medulla after we finished those of the adrenal cortex. طبعا تركنا الادينوما، الكارسينوما، الادرينوجينيتال syndromes اللي هي نتيجة excess sex hormones أو androgen secretion with virilization with masculinization effects on the female or newborn babies. In the adrenal medulla, the most important pathology are the tumors. Tumors, we have two. We have the pheochromocytoma. This is from the chromaffin cells. Oma mean mostly benign tumor. And there is also a tumor occurring in the pediatric age group is the neuroblastoma. We will discuss here only the pheochromocytoma. This is composed of the chromaffin cell, the constituent cells for the adrenal medulla. These cells still, even in pheochromocytoma, because it is a benign or well-differentiated tumor, they still synthesize and release catecholamines, the epinephrine and norepinephrine. There is a rule of tens that easify the memorization of the features of pheochromocytoma. For example, 10% of pheochromo are familial, occurring in the setting of familial endocrine neoplasia syndromes اللي ناقشناها بالمحاضرة السابقة. There is also the 10% of extra adrenal location، يعني ممكن في 10% من الحالات الفيوكروموسايتوما تصير خارج الادرينال. In such situation, I will call them as paraganglioma because they occur in the paraganglia. 10% of cases of pheochromocytoma are bilateral, especially in the familial cases, and 10% are biologically malignant, which means that I am dealing with 90% benign cases, 10% malignant cases. Okay, which one will be malignant, which one will be benign? Nobody knows. Nobody can predict that. You will define malignancy or benignancy on the presence or absence of metastasis, only for metastasis. Grossly, pheochromocytoma present as a mass in the adrenal gland. It will be either small or it could be either large, small circumscribed, large and develop hemorrhagic areas, large hemorrhagic mass. Microscopically composed of polygonal to spindle cells and their supporting tentacular cells. These cells divided into small nest by a delicate connective tissue with rich vascular network. The pattern is called Zalbalin لأنه اللي وصفه هو German physician, وسماها cell ballen بمعنى اكو balls of cells. balls cell ballen ball of cells. The cytoplasm of these neoplastic cells is granular. Why? Because they contain catecholamine granules. يطلع granular خصوصا إذا تستخدم special states. Even in the benign cases there could be a vascular and capsular invasion. هنا الحال يختلف عن الثايرويد. وجود vascular or capsular invasion does not mean we are dealing with a malignant tumor. Also, if there is atipia is not diagnostic of malignancy. The diagnosis of malignant pheochromocytoma depends on the presence of metastasis. هذه هي definitive feature اللي تميز benign from the malignant. تروح إلى lymph node, إلى lung, liver, to the bone, ومثل ما قلنا in 10% they are. What about the clinical features of pheochromocytoma? Most characteristically, there is isolated paroxysmal episodes, نوبات من الهايبرتنشن في نصف الحالات with associated symptoms like tachycardia, palpitations, headache, tremor, and sudden abdominal symptoms. These are all symptoms due to overproduction of catecholamines by the neoplastic cell. How will I clinically or laboratory diagnose the pheochromocytoma? Increased urinary excretion of free catecholamines and their metabolites. ليش اعتمدت على urinary excretion؟ لأنه level of catecholamine in your blood is not constant over time. لذلك أحتاج urinary excretion. إذا there is an increase معناته urinary excretion will be increase حتى لو كان هذا الانكريز على شكل نوبات خلال ال 24 ساعة الماضية. The metabolites of the catecholamines like the vinyl mandelic acid is also very important. This is gross morphology of pheochromocytoma. The tumor is enclosed within an attenuated cortex. هذه الاتنيويتد cortex الصفراء اللي تحيط بالتيومر ماسه هنا. Residual adrenal gland is seen in here, residual medulla and residual cortex. The tumor shows large hemorrhagic areas because of the large size. You cannot judge this as benign or malignant حتى لو كان هنا مسوي لي infiltrative or invasive behavior. فقط الميتاستاسيس مثل ما microscopically هذا اسميه cell ballen architecture بمعنى عندي balls of cells هنا مفصولة بconnective tissue stroma with rich vascularity. All of these are vascular structures. هنا on higher power the names of cells might be not very well discerned like in this photo. However, you can see the quality of these cells. They are polygonal to slightly spindled, and even if you see a bizarre, monstrous, large nucleus and cell like this does not mean you are dealing with malignant tumor مثل ما حكينا أيضا. شكرا جزيلا. 4 محاضرات انتهت. حاولنا نختار مجموعة من المواضيع على قدر المستطاع. ظروفنا صعبة جميعا خصوصا مع ضيق الوقت وتداعيات الوباء. نسأل الله التوفيق لكم جميعا.